I think we next have Dr. Manav Wadhawan. I don't think anybody needs any specific particular introduction in the field of liver illnesses and liver diseases. So he's the senior consultant hepatologist at BLK Super Specialty Hospital in New Delhi and has a vast amount of experience and treating patients, with medical management and also managing patients through liver transplantation. So I now would like to speak to him, request him to speak to us about in favor of tips with this question, which I think Dr. Charles Panekal has actually picked out. 50-year-old gentleman with cirrhosis and MELD sodium 12 with refractory ascites. Over to you, Dr. Manav.
Thank you, Dr. Rajiv. While I'm loading my slides, I must thank the organizers for asking me to talk on this. This topic is actually very close to my heart. This is exactly what we do for to a patient of cirrhosis who has refractory ascites and MELD less than 15. In our center, we will do a tips, and I'll try to convince you why we do that. Just give me a sec. Let me just organize my slides here. Yep. I hope you can see it now. Right. So the case scenario given to me is a 50-year-old man with a MELD sodium of 12, obviously a cirrhotic. Let's see what is refractory ascites. We all know the definition. It's ascites that cannot be mobilized or recurs early and cannot be prevented with medical therapy. You may have diuretic resistant ascites. That means you build up the diuretics to the maximum and you still cannot mobilize it, or you have diuretic intractable ascites. That means the moment you start increasing the dose, the patient develops renal dysfunction. In either case, it is very important you have to do something about it. Why? Look at this slide. The mortality which you have with refractory ascites is to the tune of 70% over a period of 2 years. So you need to do something about it. What are the options? This is the index case. So I thought instead of MELD sodium of 12, let's expand it further. Let's give some more leverage. Let's make it MELD less than 15. So even MELD 13 and 14. If you look at this kind of a patient, the bilirubin has to be less than 2.5. INR is less than equal to 1.4 and sodium should be more than 137. Whichever permutation combination you put, these three parameters will remain like this. So this is, I would say, except for refractory ascites, this patient has a well-preserved liver function. I have no information on etiology. That makes slight difference in the management, but not exactly in deciding who gets tips, who gets transplant. But for the sake of it, I thought, let me put it here. Alcohol, B and C I put together. NASH I put separately. I'll discuss this towards the end of my presentation as the last slide. So what are the options for refractory ascites? We need to treat it. Mortality is very high. First option, repeated large volume paracentesis with albumin. Obviously, that is not a good option. The other two options you have are transjugular intrahepatic portosystemic shunt and liver transplant. Let's first see what you achieve by doing a transplant in that guy. Transplant is an excellent mode of treatment. My dear friend Dinesh Jothimani is going to impress upon you why it's better to do a transplant. I'm trying to do the otherwise. So let's see where you support and where you vote. So with a transplant, what are you looking at? You are looking at a 1 year survival of 90% and a 5 year survival at best of 75 to 80%. That's what we are looking at. We all agree on that. So let's see what tips gives us in this group of patients. I'm not talking about tips in general. I'm talking about tips in a guy who has a MELD sodium of 12. In fact, MELD sodium of less than 15. So the first question I'm going to answer here, does tips improve survival? Look at the data here. I'm sure Dinesh will quote this study. This is a meta-analysis published way back in 2007, which included 4 randomized controlled trials, which compared tips with LVP plus albumin. Of course, it showed advantage with tips, but he'll tell you that if you look at the survival, at the end of 3 years, only 40% of patients are alive. So this is this meta-analysis. Let me give you some more detail about this study. If you categorize, let's categorize the patients who underwent tips into 3 groups. There's a group which is age 60, bilirubin is 3 or more, and sodium is 130. There the mortality is very high. Look at the group where we are talking about, age of 50, bilirubin around 1 and sodium of 140. So a near normal bilirubin, a normal sodium and a younger age guys, you are looking at a 3-year survival of 80%, 2-year survival of 85%. Sorry, 85%. That's what we are looking at. So you may ask me that this is still inferior to the transplant. So let me again give you a disclaimer. This is a 2007 meta-analysis. All 4 randomized controlled trials in this used uncovered stents. The major morbidity and mortality was associated with stent dysfunction, which actually 3 of these studies described, and it was seen in 37 to 100% of these patients. Every single patient received an uncovered stent. Dr. Dinesh told you that's not the state of the art now. The standard practice these days is that you use a covered stent. You have also decreased the diameter of the stent from 12 millimeter to 8 to 10 millimeter. 10 millimeter is what we use. Some people are using 8 millimeter also. So how does that help? Does that change the scenario? Let's look at what data we have here. So do covered stents give you a better survival? I would say yes. To support my claim, let me present to you a randomized controlled trial published in 2017. This is a French study. 62 patients were included. 23 were randomized, 29 were randomized to TIPS, and 33 to LVP plus albumin. And they defined refractory ascites as a standard criteria. Look at the baseline characteristics. Look at the MELD score here. 12 plus minus 3, 13 plus minus 3, exactly the MELD score we are talking about. MELD score less than 15, preferably in the range of MELD sodium of 12. Look at the survival. In the TIPS group, if you are doing TIPS for refractory ascites in a patient who has well-preserved MELD, you are looking at an overall survival of 82 to 100%. This is a confidence interval, overall survival of 93%. Compare that with LVP, obviously that will be inferior, but compare that with transplant. Similar, if not better. So at the end of 1 year, the results are similar. That's not the only paper published. Let's look at another paper, which was published 6 years before that. This was not a randomized controlled trial, but they analyzed 105 cirrhotic patients with refractory ascites who underwent TIPS with a PTFE covered stent. Again, covered stents we are talking about, not the uncovered ones. What they found out was the factors which are associated with improved survival are higher platelet counts and lower bilirubin levels. So if you have a bilirubin level less than 3 and a platelet count less than 75,000, the survival was 73% compared to 31% if you are exceeding those criteria. So if you are doing a TIPS for a refractory ascites and the patient has a well-preserved MELD, a well-preserved liver function, you are actually doing him a favor. I showed you this slide. I am going to reiterate this. In the subgroup of patients who have a MELD less than 15, with uncovered stents, you are looking at a 80% 3-year survival. If you are using covered stents, you are probably adding more than 10 to 15% survival here. So 90 to 95 survival at the end of 1 year. If you are using a covered stent for a refractory ascites in a guy who does not fit into criteria for transplant, his MELD score is less than 15. Which patients do well? This paper, they on a multivariate and a univariate analysis, they found out 3 factors which predicted which patients are likely to do well. INR, sodium, and bilirubin. And mind you, all 3 are a part of MELD sodium. So except creatinine, all 3 are come into MELD sodium. So you have a lower MELD sodium, you have a better chance of TIPS working and the patient surviving better. That's not exactly the end of it. Let's look at what are the other benefits which TIPS provides. Now, I think Dinesh again is going to tell you that transplant gives you improves sarcopenia, improves quality of life. So I thought, let me give you data on what TIPS does on these parameters. Let's look at bleeding episodes. Dr. Dinesh Jothimani told us, you do TIPS, the bleeding episodes do decrease. But this is the trial which I talked about, the randomized control trial. Bleeding episodes over a period of 2 years were 0 in the TIPS arm. The umbilical hernia related complications were nil. You look at plasma renin activity, you look at plasma sodium after doing TIPS. In the TIPS group, in this, there was a significant improvement in PRA. So PRA improves. The HRS incidence goes down. The renal functions improve. This is what TIPS is doing to the overall hemodynamic status of this patient of cirrhosis. Look at the serum sodium from 135 at the end of 6 months went up to 139, again statistically significant. So it is improving the overall hemodynamics. It is improving the sodium homeostasis. It is improving the renal functions. That is what is contributing to the increased survival in this subgroup of patients. Let's look at nutrition also. Now, the first paper was published in 2004, but then we had 8 trials which talked about the nutritional improvement in patients who are undergoing TIPS, whether for a varicose bleed or for a refractory ascites. Total 8 studies, almost 150 patients. And every single study has shown that the body cell mass improves, The BMI is improved, the ascites decreases, the overall body weight minus the fluid improves with tips. That is what you're wanting to achieve in a cirrhotic patient. You want to alter their metabolism, you want them to gain weight, you want to improve their sarcopenia, and tips is doing that, provided you are selecting a patient who has a lower MELD. Quality of life. 2000 paper. I guess 1 minute left, I'll finish in 1 minute. So quality of life also improves in a patient who's getting tips for refractory ascites if you have a preserved MELD score. I'm sure he'll tell you about the HE part. The Salerno paper in 2007 told us that the HE episodes are more in patients who undergo tips as compared to LVP. Again, let me give you a disclaimer here. They were 12 millimeter stents. They were uncovered stents. They often get blocked. The pressure reduction is much more with a 12 millimeter stent. You want to prevent HE, you give an 8 millimeter, 10 millimeter stent. It works equally good to move the refractory ascites, and the HE incidence is less, and which has been shown significantly in this trial and many other trials. And whatever, if the patient develops HE also, most of the HEs are going to resolve on medical therapy and patient remains encephalopathy free. Again, the bottom line is the liver function should be preserved. So our case, let's say he has alcohol B or C. You do tips, he stops alcohol, or you treat B or you treat C. The liver function status improves, tips makes other improvements, the patient lives for a longer life. For a life without transplant, without immunosuppression. If you have NASH, you have lesser ways to prevent progression of liver disease. This patient may require a transplant in time to come, but again, you're going to buy 2 or 3 years before he needs a transplant. In an odd patient who worsens after tips, you can still offer a transplant. So I would say that tips should be treatment of choice in a patient who has a MELD sodium below 15, irrespective of etiology. If you are not, you might be able to prevent a transplant in this guy. He may not need it ever. Even if you're not able to prevent, you'll buy time. You'll give him at least 2 to 3 years without a transplant. And that 2-3 years is a lot of time. Thank you for your patient listening. Thank you.
Yeah, Rajiv, you want to carry on? Rajiv, you're not audible. Okay, while that is being sorted, Manav, excellent case you put forward. I'm sure Dr. Dinesh will put his case forward now and come with some strong rebuttal. Over to you, Dinesh. Dinesh, of course, is from Raleigh Institute. He's a senior consultant hepatologist. Is a good friend. And over to you, Dinesh.
Thank you, organizers. It's been a fantastic evening. I'm really looking forward for this. Let me just make it full screen. So yeah, my dear friend Manav spoke a lot about tips, and I wonder what he does in reality when there's a lot of options for these patients. So this is a 50-year-old gentleman with cirrhosis and refractory ascites. Manav showed what the definition of refractory ascites is. Refractory ascites means you cannot mobilize the ascites by any means, either using maximal diuretics or when the patients develop complication. It occurs in 10% of patients with cirrhosis. And refractory ascites, when somebody develops, the survival is less than 50%. Okay, that's the important point. That's why I highlighted red. So it's not something you need to take into consideration. You need to ignore. It's something very important you need to take into consideration. Now, what is the problem with MELD score? Why are we hell-bent on MELD? MELD score, when it comes to ascites, it doesn't take into consideration. Okay, so this is a very important point. So in this case control study, they classified patients with MELD and then subclassified according to the varices or presence of ascites. In a low MELD patient, say MELD less than 18 in this scenario here, if we have ascites and varices, the chance of death is around 12.9%, the odds ratio of death. So it's not just MELD score, Manav, it's more to do with the ascites and the refractoriness of the ascites. That matters a lot, actually. And this study clearly shows low MELD patients, if they have refractory ascites, they are associated with very poor outcome. And also, if you see in patients with refractory ascites, we know that when they have refractory ascites, type 2 HRS, when they develop the type 1 HRS, the mortality is extremely low. Okay, and this is one of the important study where if you have HRS, your survival is extremely poor in the 12 months. So compared to patients with liver disease of other transplant candidates without refractory ascites. Now, why refractory ascites is important? Because it has other components. One, we saw the HRS. Now there's hyponatremia, which is linked to the MELD. The reason for hyponatremia linked to the MELD, because that is also comprises refractory ascites. So if you look at this landmark paper, here if you clearly see serum sodium concentration were significantly associated with mortality. So if you read here, so every 1 unit reduction in sodium, there is increase of hazard ratio of 1 of death in patients with liver disease and ascites. So refractory ascites is not a joke. It's actually a serious disease. Not only that, when somebody has refractory ascites, it doesn't just affect the liver, it also affects the heart. In this study, beautifully shown in Journal of Hepatology last year, the cardiac performance assessed by left ventricular stroke work index is being significantly impaired in patients with refractory ascites. So these patients are associated with increased waitlist mortality. So this study concludes that compromised cardiac performance is more common with patients with refractory ascites, leading to waitlist mortality. So here, I don't think the TIPS is going to work. Okay, let me go into the TIPS-related studies, some of the studies Manav showed. After his talk, I had to modify some of these studies, okay, because I included a few. Now, so this is the TIPS, covered TIPS in patients with cirrhosis and recurrent ascites. Okay, this is from over 7 years. Okay, they chose only 29 patients in 7 years. Okay, and then they compared with large volume paracentesis with albumin. The primary endpoint was 1 year survival without transplantation. After that, we don't care actually, after 1 year. So yes, TIPS showed a better primary endpoint because the primary endpoint was only 1 year compared to large volume paracentesis. But let's look at more in detail. The exclusion criteria. So the patients who had more than 6 large volume paracentesis within previous 3 months were excluded. That means they excluded the sicker patients. Patients expected to be transplanted within next 6 months or on the waiting list were excluded. That means they excluded transplant patients. So this study was conducted in patients who are not candidate for transplantation. So which means that anyway they have anyway they don't have a choice. They have to be TIPS otherwise. Let's look at some more studies. Interesting one. So this is when I started MBBS. This is when I finished my hepatology training. So over 17 years, 40 patients, that's all. Okay, and in that, only 23 patients for refractory ascites. Look at the patient numbers over 17 years. It's just unbelievable. And if you do TIPS in these patients for refractory ascites, look at this. Results are very appalling. 25% will die within 3 months. The median survival of TIPS patient is six months. And 1 year survival following TIPS is 42%. Look at here, 1 year survival is 42%. 5 year survival is 7.5%. That's it. End of story. So do you really think TIPS is going to work in this group of patients with refractory ascites? Now, let's look at patients with low MELD. See what this study shows. So they compared TIPS and large volume paracentesis for refractory ascites. Yes, the cumulative probability of survival of 1 and 2 years is excellent. It's 80 and 64% with TIPS compared to large volume paracentesis. But look at the patient selection. They chose patients with MELD of 9.6, median MELD of 9.6 for TIPS. In a patient with MELD of 8 to 9, the 3-month mortality is only 1.9%. I would be happy to manage this patient with diuretics and strict salt restriction and carry on rather than subjecting them for tips and getting them into hepatic encephalopathy. Now, this is a very interesting data published, I think, last year. So out of 389 patients who had TIPS implantation between 2004 and 2014 over a 10-year period, 10.8% developed complication, that is 1 in 10 developed procedure-related complications. 1/3 of them developed hepatic encephalopathy. 9 patients died in the hospital and 23 died within the first week. I wonder, is TIPS really safe? We need to think about it. We need to offer what is the best for the patient. So this is the early mortality associated with TIPS in these patients. These are done for refractory ascites. And when they develop hepatic encephalopathy, we know that nearly 30 to 40% develop encephalopathy. When they develop encephalopathy, their survival actually drops to less than 20 to 30%. And you are converting somebody who's a stable patient to a very sick patient in no time. And also, when they develop acute hepatic decompensation following TIPS, you're finished, your survival is gone. So what are we achieving by doing TIPS? So I told you earlier, nearly 30 to 40% of them develop encephalopathy within the first 2-3 weeks, and this leads to significant poor quality of life. They can't drive, they can't do their usual things, they become very dependent on their family members. This is not acceptable. So let's look at what Cochrane says. The 5 randomized trials, so 330 patients, there is no difference between TIPS and large volume paracentesis in 30-day mortality or 24 months survival. Whereas the hepatic encephalopathy is significantly worse in patients with TIPS, which we all know about. Yes, I agree, TIPS removes ascites, but what else does it do? It just gives you very poor quality of life. So there is no difference in mortality, the 30-day and 24-month mortality between the two groups. This is a bomb for TIPS. So on the other hand, if you have refractory ascites, liver transplantation is the best option. And the people who are experts in TIPS, they also say that liver transplantation, if it is likely to happen, TIPS is best avoided because it leads to a lot of other issues. And let's look at the EASL guidelines. MELD does not reflect all complications. There are MELD exceptions, and the first one is refractory ascites. Manav, I'm sorry, this patient requires transplantation if you have refractory ascites. So in my view, TIPS reduces portal pressure. So therefore it may benefit in varicose bleed. However, refractory ascites is an indication of poor liver disease, worsening liver disease, poor liver reserve and function. TIPS will not alter the underlying liver disease. TIPS is going to reduce your portal pressure and alter the hemodynamics. So let's come back to our case. If you have a 50-year-old guy, cirrhosis, refractory ascites, if you do TIPS, if you develop encephalopathy, you're converting an elective situation to an emergency transplant, where in India, there's a lot of problems with organ donation. We don't get organ that easily. So you need to run around to find a family member who can donate. If it doesn't develop encephalopathy, we know that survival is not going to be great long term. He's still likely to require liver transplantation as the best curative therapy. So then why TIPS? And moreover, as I said, if there is no family member and if he develops TIPS, if he develops hepatic encephalopathy, how are you going to salvage this guy? We are in soup. And if there is a family member, then why TIPS in the first place? You can wait as well as consider transplantation when it's required. So I would offer him liver transplantation, considering refractory ascites as poor outcome in patients with end-stage liver disease. Thank you.
Okay, great. Dinesh. Okay, I'm now confused. Manav, in the interest of fairness, I would give you a chance to rebut.
Absolutely, I really need that. So Dinesh is trying to twist the facts to suit his case. I'm sorry, Dinesh is a very dear friend. Sorry, Dinesh, I have to say this. So let's start from the beginning. He said refractory ascites means high mortality. I told you that. He says in a refractory ascites guy, the patient dies because of HRS, hyponatremia, low mean arterial pressure, which he develops over a period of time. I showed you data that if you do TIPS in time, you improve the HRS, impending HRS. So it's not a HRS. If you have a HRS, the MELD sodium will not be 12. Your creatinine is normal with refractory ascites. You do a TIPS, you are actually protecting the guy from developing HRS. Your hyponatremia improves and the mean arterial pressure improves. All three improve if you are doing early enough TIPS. Early enough means a lower MELD sodium. He talks about a study which he says that it was offered to patients who were not candidates for transplant. Dinesh, if you look carefully, anybody who has a MELD less than 15 is not a candidate for transplant in routine sense. So most of these patients were not a candidate for transplant because they did not reach the MELD criteria of 15. The poorest results you are quoting in a trial which did TIPS for hepatocellular carcinoma, if you remember the paper which you quoted. So I'm pointing that out. Who does TIPS for hepatocellular carcinoma? Obviously, you're going to have a low survival. Hepatic encephalopathy is an overrated thing. If you look at data carefully, HE happens in 3 sets of patients. Patients who have poor liver reserve as manifested by high bilirubin, as manifested by low sodium, as manifested by high iron. If you take these 3 things, they will never have a MELD sodium of 12. So we are talking specifically a group of patients who have preserved liver function tests, who have no history of encephalopathy, and they have refractory ascites. The patient who fit in this bill classically are alcoholic liver disease. If you ask Dr. Tripathi, how often does he see these kind of patients? ALDs are typically the patients who have preserved liver function but very bad portal hypertension. They'll have low MELDs but refractory ascites. You give them TIPS, you improve everything. Cochrane study you talked about. Cochrane study is again all uncovered stents. Stent dysfunction 37 to 100%. Morbidity, stent dysfunction. We are not using uncovered stent these days. So what I'm saying is, see, I work in a transplant unit. We do transplants as much as you do. In a guy who has well-preserved liver function with refractory ascites, without HRS, I will offer him TIPS even today. And that's what we do for our unit. And that's my rebuttal. Thank you.
Okay, thanks, Manav. Dinesh, do you have anything to say? Then we'll open for questions.
See, just go back to the point actually, because yes, I agree that TIPS improves your, renal function, hyponatremia. That's understandable, but it doesn't alter the underlying liver disease. The severity of liver disease is still the same, because the hyponatremia in patient, it's like giving albumin to somebody with low albumin. It doesn't correct the underlying liver disease. It just changes your perspective. That's it. It changes the way you look at it. You give tolvaptan. Tolvaptan doesn't alter your liver disease. It improves your sodium. It's like that. It's a glorified version of those drugs, actually. So in reality, it may not alter the overall survival in TIPS patient. And moreover, when these patients get into encephalopathy, believe me, it is difficult to manage. And the family will question you, actually. And there are technical expertise required, a lot of things required. It's not just we do TIPS and forget about it. And most of the studies, they only talk about maximum 1.5 years. Okay, I would offer what is the best solution for this guy. That is what we should look at. TIPS may be a bridge in the long term, but in the short term, but certainly in the long term, it's not going to benefit them.
Oh, sure.
Whereas if you do for varicose bleed, they are different. They're different ball game actually, because you're predominantly targeting the portal pressure.
Okay, perhaps I can start with the question and also get Dr. Dheeraj's opinion if he's still on board. Maybe this you guys will agree. There's a question from the audience. Who should be doing TIPS? Should it be the gastroenterologist or the interventional radiologist?
Of course,
intervention.
The guy who's trained specifically trained for it. The decision has to be taken by the hepatologist, gastroenterologist. But obviously, somebody who's trained for a procedure should be doing the procedure. I'm very clear about that.
Okay. Dr. Dheeraj, are you still there?
I am, yes. A very interesting debate indeed.
So what would happen in QE Birmingham?
I think we have to put this all in context, don't we? And what part of the world and what the systems are like with regards to liver transplantation, access to liver transplantation, So MELD sodium, we have I'm sure you've heard of the UKELD score, which is basically the UK version of MELD sodium. Sodium is very, very important here in terms of prognosticating. I think we're agreed on that. And that we have actually presented recent data from our center in a retrospective series of over 150 patients, half of whom had covered tips, and the other half underwent large volume paracentesis. And particularly to pick up on the point about the short-term versus medium long-term survival, the studies don't really go out very long in terms of long-term survival, whereas our follow-up was a lot longer. And the bottom line is that these patients do really, really badly in the long term, really badly. So we're talking, 5-year survivals around the 20 to 30% mark, which is appalling, whereas in transplant gives you a 5-year survival of around 70 to 80%. And in fact, most of our patients have alcoholic liver disease, and they do particularly well. The cancer patients don't do so well. So actually, I was a bit surprised at our own data, just how badly these patients. These are refractory acidic patients who require large volume paracentesis, most of them every 2 to 3 weeks. And the longer term outcome is really, really poor. If you look at just 1-year survival, we're talking 60, 70%, and then there's a rapid dip thereafter because things catch up on them. You're not altering the natural history of the liver disease. Clearly, if you're looking at etiology, alcohol is important. I've had a number of patients who actually stop drinking properly, and the ascites dries up. But the other conditions, NASH, and if it's no SVR with the antiviral therapy and Hep C, they do very, very badly. So their outcomes beyond the 1 to 2 years is really, really poor. So I was surprised at our own data. Obviously, it's retrospective, but I think we have to be extremely careful with patient selection. And what I wanted to ask a question was, obviously, you've picked up on that Bureau paper, which identified platelet count and the bilirubin as key. It was a retrospective study. It's probably not as powerful as RCT, but still, I would think those two parameters are important in deciding whether a patient is suitable for a TIPS. The other thing that I think is worth mentioning, absolutely no way would we offer a TIPS to anybody who's got a history of encephalopathy, either overt or a covert encephalopathy. So I don't know what testing. Obviously we have the psychometric testing, the EEG, critical flicker frequency, whatever method, and there's a Stroop test as well. So I think these patients, you have time. This is not a variceal bleed. This is elective. So you've got time to work a patient up. And this is where the patient selection is absolutely important. I think you'd really kick yourself if you got that wrong, because you actually had time. Whereas, the call for a patient who's coming with a bleed is very different. Oh my God, I've got to make a decision in hours. Whereas here you've got days or even weeks to make that decision. A patient isn't going to die in 2 or 3 weeks of refractory ascites. So I think the patient selection is important. So those biochemical parameters are important. MELD sodium or UKELD, and also the cardiac aspect. So I pick up on the cardiac aspect. So these are patients with a very hyperdynamic circulation, and it doesn't take a lot to tip them over. So the angiotensin system is in overdrive, and just the slightest one episode of SBP, and they may actually just succumb to that. So it doesn't take a lot for them to be tipped over. So we would normally do not necessarily get a cardiology opinion, but at least do the basic workup with the ECG and BNP. NT-proBNP has been shown in a French study, the Toulouse, I think, Christophe Bureau and colleagues. So we would always check the BNP. If it's up, then I'll think twice about that, because that's a marker of cardiac dysfunction, and these patients are more likely to decompensate. So I think the key really is patient selection. You have time to work these patients up, and always, where possible, discuss this patient with a transplant team before making that decision. So I don't think it's easy. I think the outcomes for these patients are really poor in the long term. TIPS has a role in highly selected patients, but I'm thinking probably it has maybe I wouldn't have thought this a year or two ago, but maybe in fewer patients. Whereas in variceal bleeding, it is a completely different ballgame altogether. I think we're actually expanding indications in variceal bleeding, whereas in ascites, I would exercise caution.
Yeah, thanks, Siraj. Manav, I have a question for you. Obviously, we all have patients with low MELs, and we've done it tips, and the ascites just don't get better. Do you have any tips as to, especially there's a question from the audience as to what is the target drop in HVPG to expect, size of stent, technical aspects, it's a patient selection to expect a better outcome for this subgroup of patients?
That's a very important question. Let me first back up on Dr. Tripathi. He's exactly what he's talked about. So I didn't talk about cardiac dysfunction when I was discussing this, but that's a very important parameter before you decide tips. So selection criteria: low bilirubins less than 2, INRs less than 1.4, only refractory ascites, good cardiac reserve as evidenced by echo. That's what you require. Now, what you asked is a very, very important question, because who is going to improve and who is going to have a liver failure? So you see, post-tips liver failure is described. Why does it happen? You are taking away whole of the blood supply from the liver. It is being diverted, and you actually may have ischemia. So the pressure difference which you are achieving has to be adequate to relieve tips, to relieve ascites, and it should not be so much that the patient develops post-tips complications. So what we are looking at is HVPG post-tips. So not HVPG, the pressure gradient across the tips in the portal vein and the hepatic vein more than 3 and less than 8. That's what we are looking at. You don't want to completely obliterate the pressure. If you completely obliterate the pressure, that patient is going to develop liver failure. So it's easier said than done. If you ask the interventional radiologist, what they do nowadays is they use either a 8 millimeter or a 10 millimeter stent, and they never dilate the tract. So initially what used to be done was you put a tips and then you dilate the tips so as to make the tract bigger. And that used to achieve a very low pressure gradient. That's what you want to avoid here. So the trick is patient selection and adequate usage of the HVPG codes.
Thank you. Dinesh, there's a question from the audience. There must be scenarios where you would advocate tips and in this particular group of patients, and could you expand on that?
Yeah, I mean, see, it's not that we don't do tips. We do tips, but extremely cautious. And see, we've done tips for patients with ectopic variceal bleeding, refractory variceal bleeding. Okay, so that's sort of gold standard scenario. But when it comes to refractory ascites, we are actually very cautious, because if you do tips, you're converting a relatively stable patient into a relatively sicker patients. Okay, and then there are a lot of issues with tips in terms of the encephalopathy. Yes, it may not happen in everyone, but if it happens, it can cripple their life. They're going to be very disabled. Actually, I've seen that. When I worked in Birmingham, these sort of patients get internally prioritized. Dheeraj can correct me. Internally prioritized for a transplantation. We cannot do that thing in India because, one, the cadaver organ donation is actually pretty poor, and many families don't have a living donor. So you understand. So it's better to list them for a cadaver and wait and try and manage them with strict salt restriction. We do focus a lot on the dietary aspect. Salt restriction, fluid restriction, and allowing the kidneys to recover, and then little bit re-challenge them with diuretics on a later date, rather than just going with tips straight away. So I worry about doing tips in that group of patients. We still manage them medically, take them through the transplantation if they can wait till 8-9 months, mainly because the organ donation is not much in India.
Okay, thanks, Dinesh. Rajiv, do you want to conclude and then move on to?
Yeah. Okay. Thanks, Matthew. You know what? It is very gratifying to see, that the questions about 22 years ago, when we all set foot into the hepatology wards, are still alive and kicking today. And there is so much of divergent opinion on tips. So I'm sure, maybe Dr. Mallikarjun Sakpal can maybe give us some concluding remarks. But I'd just like to mention a little study which I just picked up, while I was preparing for this webinar. And there's a retrospective study of people who had tips while waiting on the transplant list, which says that people who have undergone tips, do well and are actually much better nutritionally placed and renal function placed while they have the transplant. So maybe both treatment options are complementary to one another rather than sort of, competing with one another.